Hello and welcome to Everything Digital Health. I'm Marcus Bohr and I'm very pleased to have with me today Ian McNicoll, who's an old friend of mine I've known since the early days of trying to do open source GP clinical systems back in, what was it, about 2012, I think was when we first met, via the late Ewan Davis, actually, I think.
Yeah. It put me in a very difficult position because my partner at the time was working for one of the GP systems that you were trying to put out of business. So I was a little conflicted.
Yes.
My heart was with you, but in all honesty, I was stuck, man. I was stuck. No way was I going with the flow on open source GP systems.
Well, happily, that very company has made itself out of business without me having to do anything. But not happily for the GPs of Scotland, who many of whom are, I guess, just stuck because they don't have an upgrade path. But anyway, let's not get too bogged down in GP system politics. Ian, would you like to introduce yourself and tell us a little bit about yourself?
Yeah, so I usually introduce myself as being a former GP, which makes my GP colleagues laugh because it was actually almost 25 years since I did any general practice. But I still think of myself at some level as philosophically a GP. I did do it for 15 years, was a doc for 20 years before I escaped basically into the comparatively sane world of health IT. I say comparatively. So got involved. I guess got intrigued about the potential of health IT, having had absolutely no interest in computers in my school days, mostly because computers were giant machines that lived somewhere else that mathematicians and philosophers and accountants used, and I was none of those things. I could not see the relevance in any way, although I'd done a little bit of home electronic stuff. Wasn't my thing. And then I became aware of the word processor. I think it was a BBC Tomorrow's World program, something like that. And I thought, as a terrible typist and even worse writer, I thought that is something that would be magical for me, not to have to, redo all my scrappy spellings and grammatical mistakes. And at that point, I was also effectively at that point, I would have been a junior doctor and very aware of how much boring paperwork, repetition, stuff to do, which easily could have been automated. And that's, I think, when I started to explore a little bit more in more depth about what might be possible. This is pre-PC days. The PC wasn't even brought out, early 80s. So quite a strange time.
Wow. Yeah, that's going back a bit, isn't it? And I guess that, like, that story of seeing things that could be automated away is still happening. As a junior doctor, I saw things that we had computers everywhere, and the computers still didn't do the automated things that we wanted them to do. We were the human middleware.
Yeah, I think the clinical people that get involved in this world really split into two groups. The majority and the good people, I like to think, are the ones who are interested in analytics and reporting for research. They can see the value of the data. They want the data because the data will allow them to do good things. And they're correct. It will allow them to do good things. I was never bothered about data. I just wanted this machine to print me labels or write me prescriptions or, send appointments out and save time. So basically, I was just lazy and I was looking for something to, save me and my staff a bit of work. I justified that by saying if I was, not so bothered by all this stupid administrative stuff, then I'd be a happier doctor. If I was a happier doctor, I'd be a better doctor. But fundamentally, I think laziness was my driver rather than high-minded academic benefit to humanity. And I've stuck there pretty well since, I think.
Well, but I mean, I wouldn't say that's laziness. That's kind of looking to optimize for a certain thing, isn't it?
I'll use that phrase in future. Yeah.
It never ceases to amaze me how willing we are to waste the time of our clinicians and get them to do quite slow, laborious admin tasks.
Yeah.
And at the same time, we have a major problem with the amount of clinician time available, long waiting lists to see GPs and that sort of thing. And yet those same GPs were happy to waste their time. And actually the situation's a lot worse, I think, in hospital than it is in GP. So going back to that scenario, you were involved in some of that early GP computing sort of thing, weren't you?
Yeah, very, very, very early. So pre that, I did a dodge with my hospital. that they had a imaging service that required radio injections. What do you call them? Not radio injections.
Radioisotope.
Yeah, radioisotope injections. And because of the way the hospital was constructed, the imaging department that did that was quite a long way from the main hospital. And it was the duty of the junior doctors to do it. And of course, we all moaned because we had to take time off doing whatever we were to go and do these stupid imaging injections. But I realized they had an Apple II computer in their lab. And I said, look, I can't always say yes, but if you give me a call, I'll try to say yes. But here's the deal. If I, pick up most of the work for these things, can I get access to the Apple? So that's where I started to teach myself out of hours, basically sitting in their lab, trying to program this Apple II. Out of that, I got the bug, started as a GP trainee, decided I could immediately see computerization was starting to happen in general practice. Just real pioneers, very, very few people, and very expensive. It was £10,000 at those days' prices to buy a machine. Wow. I don't know how it's probably 50 grand, something like that, maybe more. So I bought an Apple, I bought a ZX Spectrum and tried to build a repeat prescribing system on that. Completely failed. I mean, the program worked, but the Spectrum just overheated and gave up. It just melted down. And said, I can't do all this. But that was it got me definitely hooked on both on programming as an amateur, or as you say, a clinical practitioner. But I think I could see the potential. And then just by chance, I decided I really wasn't quite ready to go into general practice at that point. I'm still deciding my future. And up came an opportunity to spend a year funded research fellow from the Scottish office, as it was in those days, to spend a year doing some kind of research. And right at the same time, I came across this Scottish project called GPAS, which had literally just formed. I went to the kind of introductory meeting. Very charismatic GP called David Ferguson, who himself was a working GP, but had a background in computing, and he'd written a repeat prescription system, which he'd handed over the code to Scotland, the NHS in Scotland, and there was a small team being formed, and I pitched to spend a year working with them, which was where I really got started. In my journey, I was supposed to be doing research around the benefits of generic switching in repeat prescribing systems on cost, but quickly, and I did manage to do something on that, but quickly got sidetracked to helping the guys doing some programming. Ended up as a Scale 9 programmer for the NHS, formerly on my CV, which sounds fantastic, but Scale 9 is right at the bottom. It goes from 9 up to 1 rather than 1 up to 9. But still very proud of that. And we were writing in BASIC, we were writing in C, we were working on Unix and Xenix and DOS and PC DOS. It was mad. It was completely mad what we were trying to do. And we did actually get some things to work, but it definitely was a baptism of fire in that world.
That sounds like you were really in at the very, very beginning.
It was. I say PCs were not. We worked on apricot machines before the PC actually was invented, so it was right at the early stages. And I stuck. I was firmly believed that these kind of systems should be owned and operated by the service, by the NHS. Of course, in contrast, there was a small but growing group of GP systems which essentially were commercial drivers, although all of them had quite strong clinical leads, often individual GPs who this was their passion, and they surrounded themselves with people with more knowledge in the computer science. So it was, I would say, GP computing, at least in the very early days, was very much a sort of hobbyist project. There were only one or two of the companies that I would say had a far firmer commercial kickoff. And my philosophy at the time, for a long time, was very much we're the good guys and these are the bad guys. And we were very proud of our public sector. It wasn't open. I think if open source had existed the way it does now, in particular, a lot of the ideas that came out of open source around distributed development, I think it would have been an open source project, but it was just not quite the right time.
At the time, yeah, there wasn't the same movement around open source.
Yeah,
that there is now.
Nor even the technology backup. You know, to make open source work, you need the stuff that came with Git and the GitHub and that whole environment about allowing people to work in a more flexible way. So it wasn't just the philosophy; it actually needed support with a different way of writing software.
Yeah, I think the tech infrastructure that goes behind, Git and Git forges like GitHub and GitLab and stuff like that, that's what enables all the really exciting stuff about, synchronized global development of things and the idea of contributions that come as a pull request and all that kind of stuff. The massive goods that come from open source, they tend to come by being able to distribute the source code via the internet. Whereas if it's a pre-internet thing, then I can imagine it's a lot less of an important consideration. And like back then, there were hundreds of GP systems. As you were saying,
I'm not sure there were ever. It wasn't quite hundreds, but it was in the 40s or 50s. And I went on a tour as part of that year. I went on a tour around just to see what was going on. I saw a GP system in Leeds, whose name I forget. It's completely died. I'm trying to remember. I went to visit the Vision guys, or what would become the Vision guys in London, and also went to visit Tim Benson, who at the time was ABIES. And it was Tim Benson and his colleague James Reed. Between them, they really developed the Reed coding system. So at that time, they were developing it. We needed a new coding system in GPass. We were working with something that we just would not. There were some choices, but they were all bad choices. And I saw the Reed codes and went, "That's it. We've got to use that." It's a million times better than anything I'd seen. Went back and said, "We need to adopt this as a national standard." So actually, Scotland adopted the Reed codes before England did as a national standard. And so I like to say SNOMED is basically my fault because we started it and then it all went downhill from then on.
Yeah. So yeah, for the listeners who are not familiar with Reed codes, they're kind of an early form of like numerical code where the code means a particular condition or a particular symptom or a particular, in that case, like medication. And it was just a big kind of a namespace as well as a hierarchy. So it had both functions. You could sort of say, give me all the child codes of diabetes, and it would give you various different ones. Of course, there's a lot of complexity in there because, you'd sometimes find that something like diabetes insipidus, which is a totally different disease to diabetes mellitus, would be kind of subsumed under that level of the hierarchy. Sometimes because they were constrained on space, weren't they? So they were like,
oh, huge. That was the biggest driver. So it managed to not perfectly by any means. So many challenges with these hierarchies, but it captured the hierarchies pretty well, and it did it within 4 bytes per code. Now, given we were the standard machine, the GPs were working on had 10 megabyte hard disks. That was state of the art. It doesn't take many 4-byte codes to cram your hard disk. And we were backing up onto floppies, and 720K plasticky floppies were, it was a different world, a completely different world.
But it's important to sort of see, because that's like how that's how Reed codes evolved that way. If you were doing them now, you wouldn't have to do them that way because you're not as resource constrained in terms of storage. And so 4 bytes, and then they extended it to like 5 bytes, and then you had CTV3. So this is the kind of evolution of that coding system. And then CTV3 was fully subsumed into what's now called snomed-ct. So now we currently use snomed-ct, but of course, like everything, it's not everywhere. It's not ubiquitous. A lot of hospitals don't really use any clinical coding in a meaningful way. And the GP systems, although they, on the face of it, have supposedly upgraded to snomed-ct, under the hood, they are still actually just using CTV3, aren't they?
Yeah, they're using either CTV3 converted to SNOMED or Reed, older Reed converted to SNOMED, essentially, with a lot of the same problems carried through. We might get on to where terminologies work and don't work later on, but
I think there's a whole episode on terminologies, because we've had lots of conversations about this over the years, and I'd love to do that. I think where we can really deep dive into it, but I think today we wanted to talk about some of the great work that FreshEHR is doing around openEHR. It's kind of unofficially, I've ended up doing a bit of an openEHR season. I've spoken to Rachel Dunscombe and then Thomas Beale and then yourself, and there may be others in the next few weeks. So I just thought, well, it'd be nice to sort of drill down into the kind of operational aspects of openEHR as opposed to the organization or the reference model and that kind of thing. And you run a company which provides services around openEHR. Is that right?
Yeah, absolutely. So I founded FreshEHR 12 years ago, had a different name, basically doing the same thing before that. So probably all in all, I've been doing consultancy around openEHR for about 15, 16 years. Fell into it completely accidentally. I know you introduced Thomas Beale, who was absolutely one of the founders of openEHR, basically one of the brains behind the whole thing. I'm not in that group of people at all. I came on later, fell into it by accident, actually through my GP system connections, through the primary healthcare group in the UK that you and I have been involved with. Because I was trying to do a bit of programming to develop a better way of interacting with the system as a GP, something that was a bit more narrative driven. AI 15 years ago, completely useless, didn't get anywhere with it. But I needed some data models to play around with, and I thought, well, this open source was starting to become a real thing. I was looking around for, okay, I'm going to do something around medication. I can't be bothered building medication models. Somebody must have done this, give me something to play with. Came across the openEHR stuff, didn't understand it at all. I mean, I just sort of literally went, my head hurts. And I like to think I was fairly, I knew my way around this stuff, but it did things in a very different way than I was expecting. But got intrigued, went back, managed to blag a few meetings with Thomas and Sam Herd, and eventually got hired as a contractor with Ocean Informatics, they were kind of like they're almost like an academic spin-off of the openEHR team, and worked with them for a number of years doing consultancy, and then decided to kind of I wanted to be a little more independent in terms of working with different providers, because at that point Ocean had one of these data stores, the CDRs, Morand, and then who are now Better. They had come out, so I felt there was something really exciting happening here around different openEHR providers, technical providers, and I wanted to position us as being neutral across all of these. So yeah, we do training with video training modules which people can sign up to, and we also do consultancy for governments, regions, companies, mostly in Europe, but sometimes a bit further in the field. So yeah, it keeps us busy.
Sounds interesting stuff. So what sort of projects are you working on at the moment? And are there any kind of openEHR killer features, as it were, that make those possible in a way that other design philosophies might not?
Yeah, probably there's a couple that I could probably talk about, and I guess the one that I'm probably most proud of all the work we've done, even the stuff I did to still with GPAS, is the London UCP, the Universal Care Plan. So that was quite interesting because this came out of an existing legacy application called Coordinate My Care, which was really end-of-life care records for people in the London area. Had been going for at least 10 years and had been reprocured at least once. I can't remember, the original company had it. And then InterSystems got the second iteration. And when I was working with Ocean, we were actually we were involved in that procurement in competition with InterSystems. We didn't get it. In fact, we walked away for lots of business reasons that don't really matter here. But we knew quite a bit about what this system did and what the kind of mindset of the people involved was, and we knew that they quite liked the idea of openEHR. Anyway, it came up for a further procurement, and we were part of the team that bid for it and then finally got it, along with Better and a number of others. And one of the reasons was that what the London team wanted to do was to move out with the kind of core of end-of-life care, because they recognize that there's a lot of overlap. A lot of the things you need to know about someone if you're delivering good quality end-of-life care are actually not about end-of-life care at all. You need to know their communication needs. You need to know their personal preferences. You need to know their lasting power of attorney. Well, all of that is exactly true. It doesn't matter what condition or situation they're in. If you go into hospital, somebody's going to ask you all these things. And they recognized that there was something around broadening the scope of emergency, let's just call it emergency care planning, that to cover a whole lot of different modalities. And what they saw in what we were able to show them through the openEHR stack and the modeling layer was that we could adapt and extend very, very quickly. What they weren't so clear about was that asking us to do this in 7 months, which was the time scale we had to deliver it, was actually insane. And it was an absolutely hard stop. It's possibly the scariest thing I've ever been involved with in my life. You know, this was live. There were 50,000 live patient records, end-of-life care. By no means, you know, high value stuff. Do you get resuscitated or not at the end of it? That's a big deal if you get it wrong. And we had to do the whole analysis of what was there already, you know, discuss with the intersystem guys. And to be fair, they did a great job. You know, I know that commercial entities sometimes are, you know, suspected of not playing it straight, but they did. You know, they were very giving and helping and essentially getting their system decommissioned. So credit to them. But still, it was a really tough gig. We could not have done that if we hadn't already been working on an end-of-life system, which didn't actually go live, but we were able to reuse all of the archetypes and a lot of the templates and a lot of the ideas, bring them to the table. And obviously stuff that was already developed internationally that we hadn't developed ourselves. So it started to show the value of this thing, that if you build these components, you can bring them together. Yes, you have to adapt them. We did have to develop some new archetypes, data models for this project, but it starts to speed up development enormously. And the other major factor is that the way openEHR works, when we've got all those data model components that we assemble as clinical informaticians, so this isn't engineers, it's people like you and I, not necessarily the frontline clinicians, it's people with a specialist interest in clinical informatics, working with the clinicians, defining the data models, defining the data set. Once we've got that, we apply it to this, what's called a CDR technology, clinical data repository technology, which is really a wrapper around some kind of database. But it's all driven by an API, and it all works in real time. So if we, you know, as we did, we added our new, you know, DNA CPR or CPR decision data models. We don't have to go to an engineer. We don't have to go to a software engineer and say, turn that into an object and turn it into, you know, some kind of computer artifact. He doesn't then, or he or she doesn't then have to go to a database engineer and say, hey, how are you going to represent that in your relational database? It just works. So my technical colleagues hate when I say this is a no-code environment, but from my perspective, it is. That massively speeds up the process, or at least it lets us get things wrong and iterate them till they're right, because we don't have to keep going through that long cycle of me speaking to a software engineer and I'm speaking to a database engineer, and it goes round. So we can speed up that communication, and hopefully we get it right and the CDR handles it. And once it's in there, you know, it's a full-blown technical artifact. You can query the data back, you can update it. So everything just works as a normal database would, but through this abstracted REST API layer, which is phenomenally powerful.
So you would have, to get to that point, you've identified the archetypes you want to use, I'm presuming, and you bring them together in a template that might be for a particular clinical task or something. So you mentioned DNA CPR. That sounds like a template. This was an interesting exercise because, you know, obviously if you're doing something like even a GP system, you go, we've got to have a problem list, and we've got to have so that's one template, you know, and a medication list, that's another template, a prescription, another template. So the kind of chunks of data. So the way openEHR thinks about it chunks the data into little use cases, you know, a vital signs encounter, nurse collecting vital signs in the ward.
But this was a bit different because we were dealing with things that we now call global. These are things that are true for a patient over the whole course of their life. And ideally, you should be updating them over time. You know, you're not issuing a new document. You're updating the CPR decision if that changes. You're updating the person's lasting power of attorney. So it's a different dynamic. And so we had to do a lot of thinking about how to chunk these things up. In particular, how we're going to chunk it up, because we know this is going to vastly expand. We're going way beyond end of life in the next iteration of this thing. You know, how do we start to choose the templates, find the templates to give us a degree of flexibility? And the other factor that's in there is that to some extent, the shape of the template does match authorization. So obviously, once you're in this world where we have a whole range of health and care professionals interacting with this, with different competences and skills, all the way from a senior oncologist, palliative care specialist, through to a care home manager, all have access rights. Most have, and patients included actually, all have, or they nearly all have full visualization rights, so they can see it. But who gets to update these bits? And it did help to chunk things up into, if you like, themes, because it makes it easier to manage some of those authorization activities. So there's a lot of stuff we had to do quite quickly. We got most of it right. We discovered we got some of it wrong when we went to phase 2 and had to rejig it a little bit. But again, the fact that we could do all this, we could rethink it, rejig it without being tied down by basically getting an engineer to go and have to build it, and then we go, oh, sorry, mate, it's wrong, we've got to do it again. We could very much run it ourselves.
It doesn't take much data modeling to show you how much data modeling goes into a clinical system. If you're using something like a web framework or something like that, something non-openEHR, you realize how much you've got to build into every single model, and every single data item ends up having this, an overhead of little extra metadata pieces that you've forgotten about, and you get all of that out of the box with openEHR, like date and time of creation and things like that. It's just kind of like they're built into the reference model. Everything has them out of the box,
and you get all the stuff like versioning and updates and audit trail. So everything is versioned. So if we make a change to one of those CPR documents, the old version is kept and it's just up versioned all the time. That just happens with one of these CDRs. You just get it for free. You don't have to think about it. It just works. And that's a massive change. And I think we've been a little shy to talk about the CDR as a thing, because it feels kind of like a technical thing. I mean, these things are also vendor neutral. So we now have 4, 5, 6, 7 different companies or organizations building them. All, I wouldn't say they're completely compatible, but the degree of compatibility between them is really very high. So you can swap one out for another. So you're not locked into a particular vendor. And that's it. The people that we find really hard to talk about this are the engineering folks, because you can see most of them go, I don't know how I'd make that work. That feels like magic, nah, I don't believe it, And so for a long time, there's been a lot of resistance to, that just seems like wizardry and hackery, and, that's dodgy, just show me the database. You don't need to see the database. That's not your role anymore. The database is submerged below there, but it makes them really uncomfortable.
Yeah, I think particularly because the last 40, 50 years plus, the relational database has been the king of the database, hasn't it? So you expect to see UML diagrams and tables, and this table is related to that table through this foreign key and that kind of stuff. And then the real power of openEHR is that actually most of this is just documents that are persisted, isn't it?
Yes and no. It from a clinical point of view, it's like a document, but to make it work, people have to shred it in very clever ways, and that's what the lower level, the stuff that Tom Beale worked on, the reference model, is all about, making that very efficient. So under the hood, in fact, most people right now are using relational databases to do this. So there are tables and there are columns, but there isn't a blood pressure column, a blood pressure table. There isn't an allergy table.
I think that's the bit that people find.
And so
unnerving.
and there's a whole generation of engineers who are used to this. They're trying to understand what a blood pressure is, and we're saying you don't have to worry about that at all. Yeah, they're working at a different level of abstraction, and it worries them. Let's put it that way. But I think there are enough multi-million scale projects now around the world running on this kind of technology that are proving it. And I think the other interesting thing is that some people in the FAR community are coming into this space as well, and it tends to be called the headless EHR in America, where but it's the same principle, domain driven. In other words, you throw some FAR resources or profiles at one of these things, and it just works. Now, there's an argument to say openEHR does that better because it was designed to. We don't need to go there. I think it's more important that the idea of the CDR as a new generation of data store that is optimized to manage this really messy, complex space of health and care data. Let's not worry about whether it's openEHR or FHIR. The principle of this thing, and get away from hard coding database tables. That's the big news.
Yeah, and of course the side benefit, which isn't really a side benefit, it's part of the intention, is that if you are taking a predetermined archetype that comes with all the batteries included, as it were, it's specified down to the validation limits of it and the units, and all of that stuff is the kind of stuff you would have to do as you did your data modeling. So you're not only getting all of that for free, but by using that same data model that somebody else uses, then irrespective of the CDR type, your data is very, very likely to be interoperable, so that you could take database entries from one system that have, say, for example, blood pressure in there, and those blood pressures are going to be represented in a way that makes sense in another similar CDR that uses the same archetypes.
Absolutely. That is the goal. I'd have to say it's there's still quite a long way, and a lot of the gaps that still exist are actually clinical gaps. I can use as an example. I talked about this other end-of-life project that was called Rosie, where we actually did a lot of the preparatory work. And Rosie was a relatively greenfield site. There was an existing application, but it wasn't widely deployed. So we really made use of as many UK standards, mostly English, end-of-life palliative care standards, and some existing documentation from competitor products that had been openly published, which was good of them. So we very much built on that, and that was really what we took to London as the first cut. But we always knew that was going to be difficult, because the greenfield Rosie, that had a lot of SNOMED coding in it. It had value sets that were part of standards from PRSB and whatever, which is a UK standards agency. But the London, because we had 7 months, it had its own codes. There were no SNOMED codes. It was just local codes. It had its own way of thinking about the world. This was a carefully designed system by a group of clinicians. And yes, we could use a lot of the archetypes, but a lot of the ways they were shaped were somewhat different from the way they were shaped in Rosie. Obviously, all the terminologies were not the same. They used different value sets, lists. They did syringe drivers differently. So, this, I think it's a really, I've often thought we should write this up as a paper, because it's the limits of, to some extent, it's, where we still have to go. We need these human communications. We need the people in Rosie land to speak, the clinicians in Rosie land to speak to the clinicians in London and say, hey guys, why are we doing syringe drivers differently? It actually was geographically it was right next to London, so they were going to collide at some point. There will be lots of patients on the boundary. And that is the other really nice thing about openEHR, is it facilitates those conversations. It says, guys, you're going to have to sort this out. If you say A and you say B, there is no amount of interoperability that's really going to work. You're either going to have to decide to agree C or A/B, whatever it is, or you're going to have to forget about it and just do your own thing. And that's why I think sometimes when I see those, discussions, it's all the vendor's fault, that it's all that. Well, it's still quite a lot of it is us as clinicians who are really quite empowered to run things the way we want. You know, I think we forget, compared to other professionals at a similar level, you know, within financial services, for instance, you're not going to get a regional bank manager who tells Lloyds, look, guys, I'm doing things my own way here. You know, I've written my own bit of software, or I've changed all your forms. You know, we are actually empowered to do a lot more tinkering around. It probably doesn't feel like it in the field, but it does happen.
Yeah, well, that explains why there's so much variety in the way things are recorded, and why we have so little interoperability of systems in
it's the flip side of innovation. You know, we are, you know, medicine is hugely innovative. And part of that is because clinicians are, and not just doctors, you know, nurses are empowered. Hey, we're not going to use the Whitlow score. We're going to have our own version of the Waterloo score. I mean, you know, people do it all the time. And it's a good thing, but it's the flip of interoperability and standardization. And I think all we can do is upskill and educate clinical people that, look, we're not saying you shouldn't do your own thing, but there is a cost to that. And that may be a cost in more expensive software, or it may be a cost in poor communications across your patch. You've got to make that call, and we'll help you, you know, get the best decision there.
Just going back to the sort of archetypes and templates and the you know the way we share those, we have tools like this, the Clinical Knowledge Manager, the CKM, which is kind of the de facto online sharing platform, as it were, for archetypes and templates. And how complete is the data modeling that's in there? Say, you know, if we were to take the international or the international plus some of the countries that have really gone for openEHR, like Norway, have we got enough in there to say, let's, you could build a
complete... Are we there yet? So I'll start with the positive. I would say pretty well, typically any projects that we get involved with now, I think 75, possibly closer to 80% of the content that we require, we can take from that international space. Now, not all of it in there is published, right? So there's a formal publication process that's done through openEHR International. And that is quite, well, it's not slow, it's actually quite fast compared to most ways of doing it, but still, it takes time. Some of these things are quite hard to do. And to make sure you've got a good quality result that people can trust, it can be a little bit deliberative. So that doesn't mean you can't use the published archetype, the non-published archetypes, and we do. But you've got to expect that it's somewhat unstable, and it will probably change quite a lot before it gets to that publication status.
Yeah.
Is it, you know, does it seem cumbersome and slow? Yeah, it can at times, but it's probably better than anyone else has ever managed. So, and given particularly that this is a community that is very largely self-financing, huge amounts of pro bono effort by people from companies, you know, individuals, so, you know, a lot of people contributing to this. It's not, you know, it's not funded anything like, let's say, the SNOMED community, you know, fractions of amounts. So I'm very proud of what we've achieved. And I was lucky enough to work on with Sebastian Garda and Heather Leslie on the early stages of the CKM build design. And it was really interesting because it, you know, I built and, you know, developed some bits of software, including a bit of commercial software. And it was very much, you find out something that's there already and you copy it or copy bits of it. And you make it your own. And yeah, everybody does that all the time. This was really interesting because actually there was nothing out there. There was a completely clean idea. How do we get this to work originally? And it was about how do we build an environment where clinicians can come and comment on these things line by line, systolic, diastolic, pulse pressure, just give their views without really overburdening them. You know, make it easy for them to engage where we need to. Don't blow their heads away with technological nonsense. You know, find ways of reminding them about their invitation, because these are all volunteers. They're doing it in their own time. Nobody gets paid for this. So, you know, Sebastian in particular put a huge amount of work into making this a thing that was friendly for people to use and made it easy for them to contribute. And that was, you know, that was really, really exciting. So yeah, I think the problem is the other 20%. because the other 20% is a huge tail. It's a huge tail. And, you know, I've used, I've got a map behind me, you see, world map. And I think we are in a way mapping the world of clinical documentation. And nobody's actually ever done that before. There's actually even tiny amounts of documentation about how do you do a cardiac examination. I had a book that I had as a student that is still the current book I discovered to my horror. You know, that's like 30 years ago. It's still the same book, which I used to send me to sleep at night. But there is no source of how do you document. You know, there's lots of guidelines, but not, if you look at things like, you know, national guidelines on heart failure management, there's lots of guidance, but there's nothing in documentation. Or if it's there, you should say something about it. It's just very imprecise. So
it's always been left pretty much to what you might call almost the clinical common sense to say, well, you've done these things and you've examined these things, so you should probably write them down. But then it also gives you a certain amount of leeway to write down the important findings, and particularly the important positive findings and the important negative findings, the things you looked for and didn't find, whilst giving you a little bit of latitude to discard maybe a clinical examination test that you did. There was no result. It doesn't really matter. It's not got relevance to this particular thing. You feel as though you've got working towards a differential diagnosis. So you can deprioritize the need to record that thing, because what you're trying to do as well is convey like a clinical case now, which is going to be presented to another clinician. There'll be other clinicians involved in this care. So you're now trying to reduce the noise and focus on the signal. Whereas I do find that when computers get involved, and particularly traditional database designs result in, you know, an encounter form which has lots of was the patient blue around the face, yes or no?
Yes or
was
no?
the patient breathing fast, yes or no? And you end up with something like the kind of NHS 111 encounter report form that gets sent to GPs, and they're like, anybody who's a GP will have seen one of these, and it has probably about a page and a half of A4 of mostly negative findings of them saying the patient was breathing, that there was no weapon being brandished. You know, there's all kinds of safety questions that they include in the whole lot of that in, and then at the very end there'll be a tiny bit of usually free text that says patient had been sneezing uncontrollably 50 times in a row, so called 111 or something. And you've had to read an enormous amount of noise to get to this tiny amount of signal. And I think clinicians are quite good, left to their own devices, at reversing that ratio and giving you the meat of the point of what they're trying to talk about.
Yeah, so we really struggled with this, what we called the questionnaire pattern in the early days, because we came across that. I remember, you know, some really painful days actually out in the Netherlands working with a hospital there, where we were getting all those yes/no questions and trying to fit it into the openEHR way of thinking about data collection, which I would say is much more GP/doctor orientated, where we make statements like the patient has diabetes or their blood pressure is 120/80, whereas this turns it on its head and asks these questions like, does the patient have diabetes? Yes, no. And it drove us crazy, to be honest. And then during COVID, these questionnaires came back again, you know, all these flipping questionnaires for whatever stage of you know, the COVID crisis. And Heather Leslie, to her credit, said, look, we just have to accept this is a speech pattern or a communication pattern that actually is valid, because generally speaking, the people who are being asked to answer in this way, they don't have the competence. And I mean that in a professional sense. I don't mean they're incompetent. I just mean that they're being asked the question, does the patient have diabetes? Yes, no, because they're not empowered to say the patient has diabetes. It's a preliminary question. It's a screening question, or sometimes it's a curation question at the end of a process. And that's okay. And again, I think this is one of the interesting things, that there's actually a whole field of study about this kind of documentation patterns. This just nobody's ever done it. Maybe, you know, I'm probably too old to do it now, but these are real things that we need to tease out. And as part of our video courses, we have a section on this. You know, we used to call it questionnaires are evil, because they're actually very hard it can be very hard to figure out what's going on. Just as an example, a couple of hours ago, I was discussing with a colleague on just exactly this thing. Does the patient have measles? Yes, no. This is part of some public health work we're doing in the Netherlands. And the big discussion was, is this because the person who's answering this questionnaire really isn't allowed to label the case as being measles? Or is it just a UI convenience for the doctor? So the doctor can say this patient has measles, but it's a kind of reminder. There's a little bit of clinical, there's a bit of clinical support there, you know, because this is a critical question. So we want to answer yes, no, and we want to make you sure you answer it. What do we do with the data? Well, we put it in. If the doctor says yes, that becomes a problem diagnosis of measles under the hood. So what you see on the screen and what you put in the data is sometimes a bit different. So it's a philosophical minefield, this space. But I think we're chipping away at some of these patterns and understanding them as an approach.
It's super interesting to start seeing the level at which trying to make everything categorical, computerizing the very, very woolly medical data that we're used to dealing with, you start to reach almost like the frontier of the possibility, like where it starts to become almost impossible to make that a categorical yes no statement, and you start to get into provenancing of that data and deciding who is saying this data. Is it being asserted by someone who's made the diagnosis, or are they just reporting a previous diagnosis? Is this something we've taken from the record from a previous code? If so, who put that there? It becomes massively more complicated than what we think. And the world of a clerking, handwritten clerking in a set of notes, was delightfully anachronistic in a way, in that all of that stuff was kind of going on in our heads, and then you write it down. But once it becomes computerized, there's a whole order or two more sort of levels of magnitude of complexity, because you can drill down into not just where did this diagnosis come from. You've said the patient has measles, but where are you basing that on? Was that the patient said? Was that the blood test came back right in front of you, or is this another clinician?
I think the other thing that blurs in some people's heads that this is relatively easy is that they're seeing it from a data analysis or reporting perspective, even a clinical registry perspective, because by that time, all the hard work of collecting this messy information collected by nurses and doctors, and sometimes duplicated unnecessarily, in fact, often duplicated unnecessarily, but that we have to expect people have their own needs in this space. And then, by the time that goes out for reporting, it's been massively curated and tidied up and simplified and flattened. And I think very often, particularly government, sees this as a data challenge, and they see the data as the stuff they need to make political decisions or management decisions, which is fine. There's nothing wrong with that. But that's a tiny fraction of the whole thing. That's a massive oversimplification of the challenge as you try to pull that data through, and yes, deliver it out, to deliver care for the patient and all these other things. It's not these are the wrong thing, but they are. If you see it through that lens, you get a very skewed and simplified perspective of the challenge.
Yeah. I think we saw a lot of that in COVID, where the things like the shielded patient list, for example, depending on how you used different code sets to arrive at your list, you could either be what's almost like called a greedy query, where you get an excess of patients. It would have a high sensitivity but a low specificity. But that didn't matter, because what you're trying to do there was make sure the maximal data set was achieved, and you could then make sure that people were given the opportunity to shield, for example. But we also have the opposite problem, where you want to have a high specificity. So if you're going to provide, say, clinical decision support on a per patient basis, it has to be highly specific. It can't accidentally overtreat somebody just because the query was a bit greedy. The queries, if anything, need to be much more balanced so that they have the right level of specificity and the right level of sensitivity, so you don't miss cases, but neither do you overtreat people. And that's something that, you know, we're still at the foothills of sorting out in terms of the data modeling aspects, but also the, you know, the ref sets and terminology, clusters of SNOMED codes, for example. Because just by how you select those codes, you can make a very big difference in how your tool operates. You know?
Absolutely, yeah. I'll jump back to the CDS thing and talk about the work we're doing on pharmacogenetics, which is really interesting. But I want to just cover off the London bit with something which was that next phase, because it was always about, okay, we've done end of life, delivered, done 7 months. Next phase, okay, what are we going to do next? So what we did next was frailty, dementia, contingency care planning, the About Me, PRSB About Me standards, which is personal preferences. There's reasonable adjustments, all sorts of things. But the really exciting one was sickle cell disease. So people may not be familiar with sickle cell disease. It's a genetic condition, and it particularly affects people with Afro-Caribbean heritage. So even in UK terms, it's still a fairly relatively rare disease, but moderately common, let's say in London, where there's people with that heritage. And it has it's a major impact on people who have it. They become has major long-term health problems, but when they have a sickle cell crisis, they do get or can get excruciating pain that requires opiates, morphine, that sort of thing to control. And very often they are badly managed because they rock up at a hospital, maybe outside their own area, in extreme pain. They say, my doctor says I have to get morphine, and the cynical casualty officer who's been on for 12 hours goes, get lost, or it's unpleasant. And I've heard this story told even from somebody who was from Jamaica. You might think they'd be more sympathetic, and this happened to a friend of hers. So what we were able to do very quickly was to set up or adapt a set of sickle cell management care plan for people in different settings. These were discussed with the sickle cell patients' hematologists. It's down there. This is because the universal care plan, although it has a feeling of a patient-centric plan, and it's what we call co-produced, so patients get to see it all. They're actually able to fill in some stuff themselves. That's coming quite soon. It nevertheless is a professional grade record. Now that means that this formal, signed off, official sickle cell management plan, including you must give this person opiates in these settings, is now available to anybody within the London patch. And 80% of patients within the London area have now signed up to a sickle cell care plan within a year. You'll know, Marcus, how long it takes for any impact for this sort of thing to happen. So that's partly great calls from the London team, but it just says to me how valuable this is to a community that's been pretty badly served in the past for all sorts of reasons. It's one of the things I think I'm most proud about of all of the work that I've been involved with in my career. It's just making that one difference to a community who otherwise have had a pretty rough deal. And it was our ability to do that fast and get it working. Just again sold the benefits of the technology that we're working with.
Wow, that's a pretty steep adoption curve. That's like very impressive to get that much uptake in such a short time. Very, very cool.
It matters.
I think, thank you for everything you've shared with us today. I think it's been a really interesting episode. I'd love to have you back on, and perhaps we could, what would be really great to delve down into sort of more of the like clinical modeling 101 kind of thing, almost, without giving away any of the FreshEHR special sauce.
Absolutely. Yeah.
How do you get started clinical modeling? How do you get started if you want to be a reviewer and be involved in some of this stuff? I mean, we could give people a bit of an on-ramp into the world of openEHR. We have a forum, we have CKMs. What tooling should they be using? And where would they go if they wanted to get involved more? That would be a lovely thing to be able to do. And I think you're the very person to do that.
So
again, thank you very much, Ian, for being on the show. And I will definitely be in touch about having you back on.
All right.
Thanks very much.
All right. See ya. Bye.